acute lateral ligament injuries. Okay, so boring but yes, common, 4 to 10% in different studies of ED presentations. So we're meant to be talking about the indication technique for operative management, and to make it a debate, we're focusing on grade 3 injuries, which we'll talk about in a sec. So ATFL is usually gone, the TFL is often involved as well, and with our grading system, so ATFL, CFL, PTFL. So grading systems, grade 1s, they're kind of your stretch injuries. Grade 2s when you've got a partial injury of the CFL usually, and grade 3s when both are gone. So that's when you've got your really unstable ankles. So to make the debate, these are the ones we're talking about because it's pretty widely accepted that the grade 1 and 2s you're not going to do operative management for. So the grade 3s, they're the ones you've probably got an anterior draw or a talar tilt positive, and they're probably both ligaments are gone. So the reason why we're debating this, it's contentious over the last 50 years. There's more than 50 studies in English literature that you can find that are quite good studies. But they did a Cochrane review in 2002, and they didn't find anything conclusively from that. But lucky I came and had a look because I'll give you the real answer. So the problem with the Cochrane review is they took all 2,500 odd patients, and then they tried to have a look at whether or not operative versus non-operative technique was going to be better, but it's very difficult because all the studies were comparing different interventions. So as you know, you can't compare apples and oranges or real course pencils. As you know, depth drives are sitting outside. So, first of all, let's take something from up the top end of the scale. So we've got a good meta-analysis from JBHAS 2000. What they did, they took all the good studies, they even called the authors to see if they knew of any other good studies, and so it's pretty thorough. And what they wanted to do is they just wanted to compare the same interventions for different studies. So when they looked at residual pain, when they looked at no intervention and then progressed down to intervention, surgical intervention, and then functional therapy, they found that had the best outcome for residual pain. Similarly with giving way, which is termed functional instability, the best outcome once again was with operative then functional treatment in more studies, in the majority of studies, but it really was from a level of not doing any intervention looked like it was worst, and then as you can see, when you were just doing surgical intervention, that didn't seem to provide the best outcome, but surgical intervention and then functional treatment, the functional treatment alone seemed to have the best functional instability improvement. So the conclusion they found was that the combined therapy was probably the best, but this was also matched in some of the larger studies from that series. So that's kind of from the patient's point of view, they found that they had the least pain, and functionally they were most stable after surgical intervention and then functional therapy. Now what we all agree on is that you've got to get them moving. The longer that you keep them immobilised, poor outcomes are going to be no matter what you're doing with them. Now, how long are we going to keep them immobilised for if we're not going to do a repair? Because the ankle we know isn't stable after a couple of months. You tear the ligaments, and up until a couple of months you've still got increased anterior draw, increased talar tilt, and there's studies which show that after a couple of months they still are unstable. Also, syndesmosis, as you've already heard, often injured as well. And when you're weight bearing on these unstable ankles, your peak cartilage strain is altered. You have a peak cartilage strain which is more anterior and more medial, and it's often in the region where you see clinical arthritis down the track. So basically what we're saying is we've got unstable ankles, we've got a changed peak load strain, and we need to get them moving early. So if we're not operating on them, then you're looking at walking or mobilising on an unstable ankle with an abnormal cartilage loading pattern. Just out of interest, what do we know from ACLs and knees? We know that if you delay your operation down the track, you have increased incidence of osteoarthritis found at ACL reconstruction if you delay. And so it's just that thought that you've got an unstable joint and you're trying to mobilise on it. What happens to the cartilage? That's coming around too. So does primary repair work? We know it does work. There are studies where they've just operated on all of the grade 3 injuries, and they found that they have about a 3% failure rate, 1.5% infection. So what other benefits? We've already heard about the osteochondral lesions associated with ankle injury. So when you look at operation at the lateral side of the talus, some studies show that around 7%, a few studies show it's around 7% will have a lesion you can see just at operation when you're repairing the lateral ligaments. If you put an arthroscope in there, then some studies actually show up to 2/3 of them will have some sort of cartilage damage on the medial aspect of the talus. And there's risk of loose body formation with the lateral talar lesions as well. So when you're at operation, yes, you can look at repairing or fixing these lesions as well. What about the argument, why don't we just operate on the chronic ones? Well, we know that with the chronic ones, they do have a very high incidence of other injuries found. They have significant loose bodies, they have significant talar injuries, and we know the unstable ankle, if you have a look there too, the osteochondral lesion rates are higher than for the lateral aspect than for the acute injuries as well. So whether or not you're getting progression, and we do assume that you are getting further osteochondral damage with an unstable ankle and repeated injury. So why don't we see a benefit in the short term? So we look at lots of studies, and at 3 or 4 or 5 years things seem to be fairly similar. Well, if you look at single acute injuries in ankles that end up needing a definitive management, then the time of onset of arthritis for a single injury is actually quite long, 38 odd years. So you're seeing these patients come back from when they're 20 or 30 having injured themselves at 50s, 60s with significant arthritis, and we just don't have studies out to kind of 40 years that's going to show this. So just to summarise, we've got happier patients if we look at a repair, because you've got a patient who's got a more stable healing ankle as far as they're concerned, and also less pain. You've got happier doctors, you're normalising the load bearing for rehab, you're treating the osteochondral lesions at the time of surgery. So, and what's your knockout? Well, we're surgeons, we like to operate, and there's some great numbers there as well. So when we're talking about the Boyce technique for lateral ligament reconstruction, so Brostrom 1966 talked about direct mid-substance repairs. There's been a lot of variation on the Brostrom repair with Brostrom Gould, Brostrom Evans. Basically looking at direct repair of the ligaments seems to have quite good outcomes in a lot of studies, and seems to maintain normal range of motion. If you've got a heavier patient, someone who you might need to try and stabilise further, there are other techniques for trying to stabilise the ankle further from a simple direct repair technique, including split peroneal burst grafts and using tissue from local area to try and stabilise your repair. So I know we're probably running short on time, so just very quickly, so making a curved incision, trying to protect as many of the branches of the nerves and vessels as you can. You're incising the peroneal sheath, retracting the tendons to expose the ligaments, and you can look at doing a direct repair with a non-absorbable suture. If you've got an avulsion from the bone, then you can look at trying to use an anchor or trying to use bony transosseous suturing techniques as well. So finally, the main point from the first part of talk 2 is that you need to get these things moving. So post-op, you need a couple of weeks, depending on how strong you think your repair is, and your ATFL is probably going to be a weaker repair, or if you a CFL repair, often you can get quite good repair with that. Depending on what you think your repair stability is, that's how long you're going to time their non-weight bearing period. But you want to try and get them moving as soon as possible. You want to commence active physiotherapy, and then you want to concentrate on neuromuscular training, peroneal compartment strengthening, proprioception techniques. So, on to you, Deb. Come and give us the alternative.
How do I load my call? Double click. Beautiful. Right, so I've got the correct side of the argument. I'm going to talk to you about scientific reasons why you should treat this non-operatively. And it's practice of what we all do day to day, and I won't make it personal. I'm also going to talk to you about the fact that some of Glenn's arguments are from articles from the 1960s, just a bit more relevant. So with grade 1 and grade 2 there is no debate. With grade 3 is where the debate lies. When I looked at the topic of conversation for today, the title I didn't like was the use of the word conservative, which I think is the wrong term. So I think the correct term is non-operative functional treatment is the best outcome for these patients. Answer is very obvious. They have excellent outcomes. They have fantastic ankle scores. They return to work and sport quicker. They achieve range of motion earlier without an operation. It's cheaper to treat these patients economically, non-operatively, and you avoid the disastrous, nasty complications of operating on these patients. So going through a few studies. This is a study from Finland, which is a strong article with 14 follow-up that recruited military recruits, randomized them into 2 groups. One group was a surgical group. So this is a group that had swollen ankles after